got 4 pulmonary veins, 2 on the left, 2 on the right. Comes back to the left atrium, goes down to the left ventricle. Again, this is a big muscular chamber. It gets pumped out to the aorta. And the aorta looks kind of like a beautiful like a candy cane. This is the aortic arch, St. Louis arch. It goes down to the descending aorta. There are 4 valves. The first valve is called the tricuspid valve, tri because it has 3 leaflets. Then there's something called the pulmonary artery valve. And let's see. Oh, this is mislabeled. I'm sorry. This is actually the pulmonary artery valve going out there. Then we have on this side the mitral valve, and this should actually be labeled the aortic valve. 4 valves. These are called AV valves, and these are called actually semilunar valves. Now, in Costello Syndrome, we see basically 3 patterns of heart problems. There are many different types of heart problems. The problems that we see is that there can be something wrong with a heart defect. And a heart defect is defined as something that is wrong with the structure, which means that something has gone wrong early in development. In the first 8 to 12 weeks, something that is present at birth, but may be detected in the fetus or the adult. And I'm giving you some examples of heart defects. A heart defect might be something like an ASD, in which you have a hole in the atrium, between the right atrium and the left atrium. Or something like a VSD, in which you might have a hole between the ventricles. Anybody in the room have a child who's an ASD or a VSD? No, okay. So you know what? I'm not sure if I loaded Capra. Is there a Capra? I'm going to actually pause for a second, because forgive me, I might not have loaded exactly the right show, so just bear with me. We had a lot of loading and unloading different shows here, so let me just check. Do you remember when I talked to you before? One thing I always start by telling you is that even though I trained in pediatric cardiology, I don't practice as one. And this is important because, as you know, the doctors at this meeting try to define our roles. We try to be as helpful as possible. We're certainly here to provide information and education. But we try not to give specific information in terms of, say, drug dosages. We try not to comment exactly on some of the care that your children have received. That's even more important when it comes to cardiology. One of my things that I say to everybody is your personal doctor, the doctor who's taking care of your child's heart, certainly knows more about you and your child than I ever will. I certainly serve as the clearinghouse on heart issues for anything going on in the Costello Syndrome society. And I certainly focus on patients with heart problems and the specific topics such as growth hormone, rhythm problems, cardiomyopathy. I keep track of all the publications. I'm certainly involved in my own research. I'm certainly very interested in doctor availability. People come to me saying that they're looking for a doctor or searching for maybe a new one, and I'm very much an advocate for care. The purpose of this talk is to learn more about the structure of the normal heart, focus on the 3 main problems: heart defects, cardiomyopathy, tachycardia, and I am here to talk about some new heart problems: high blood pressure, aortic dilation, one instance we know of stroke, and a concept called artery dysplasia. I'm going to talk a little bit about some research on the heart and some reflections in general. Some of you may say, isn't that the same talk she gave 2 years ago? And in fact, it is mostly, but it's definitely new and improved. We're going to start by looking at the normal heart, going over some of the main problems, and then go over the new heart problems and the research. And what I wanted to do, and I knew something didn't look right about that first talk, because that's my kind of streamlined version, is before I get into that complicated picture of the heart, I use this analogy. I say the heart is like a home. Upstairs there are 2 rooms. We call it the right atrium and the left atrium, and there's a dividing wall called the atrial septum. Downstairs there are 2 rooms also, and those are the big, thick, muscular rooms called the ventricles. Right ventricle, left ventricle. The dividing wall of that is called the ventricular septum. And then in between the upstairs and downstairs are these valves, or the swinging doors, and those are called the tricuspid valve and the mitral valve. You've already seen this, and now you know what that is. That is really the more detailed version of the heart. Now, in addition to these rooms, those basic swinging doors, those basic valves, are the pipes, or the plumbing. The pipes that enter the house from the body are called the superior vena cava, the inferior vena cava, from the lungs to the pulmonary veins. But then we've got the plumbing that has to leave the heart. The big arteries, those really important ones, the ones that go to the lungs are called the pulmonary artery, the main pulmonary artery, and then it branches into right and left. And then the big one that goes to the body is that big arch, the aorta. There's internal plumbing, coronary arteries, and an electrical system called the conduction system. I mean, one of the reasons I just love the heart is because it's just so structural. It's really just so tangible. You can see it, you can feel it. There's nothing mysterious about it. And if you had any problems with that other version of the heart, because I find it helps to look at different versions of the heart, here's another one. Color-coded, everybody likes to color-code the heart to blue and red. Superior vena cava, inferior vena cava, ducting into the big, thin-walled right atrium. Crossing the tricuspid valve into the right ventricle, going out the pulmonary valve to the pulmonary artery. Coming back via 4 pulmonary veins to the left atrium, mitral valve, left ventricle, out the aorta. Before I go on, folks, any questions about the anatomy, or is it pretty familiar to most of you? Great. And now, back to where I was. When we talk about the abnormal heart in Costello Syndrome, we're going to talk about these basic categories. The first one are called congenital heart defects, also known as cardiovascular malformations. And it has to do with an abnormality in structure. How the heart is put together refers to an abnormality early in development, 8 to 12 weeks. Okay? So no matter what happened to somebody else later in development, terrible sickness, car accident, something else that happened, heart defects happen early in development. They can be present at birth, they're usually present at birth, although they can be detected by an echo early in development, or actually not even picked up till somebody's 5 or 10 years. And I had given you some examples. An ASD, a hole in the atrial septum, a VSD, and there are many different types. This is one showing you what's called a little membranous one, a little muscular one. But there's some really complicated ones too. This one is called coarctation, which you get a narrowing of the aorta. Remember the aorta? See the little arrow pinching in? Coarctation. Transposition, don't have a diagram for it, involves the switching of the great vessels. Doesn't occur in Costello, just an example. Tetralogy is a common heart defect in which you have a narrowing of the pulmonary artery, a VSD, and an overriding of the aorta. Truncus is something you don't even see in Costello. These are types of heart defects. But here is a type of a heart defect that is common and is something that we definitely see in Costello syndrome. It's something in which you have a tight or an abscess valve. You can have pulmonary stenosis, the single most common heart defect in Costello syndrome. It's a narrowing of the pulmonary artery. So go back to that familiar picture. Leading out from the right ventricle is the pulmonary valve. And when it's narrow, it's called pulmonary stenosis. That's the medical word. And it's drawn here as kind of thickened. Anybody have a child with pulmonary stenosis? I expect a couple people to have that. Okay, I see some show of hands there. You can have aortic stenosis, but that's extremely rare, almost not seen at all. Valves that leak are called regurgitation or insufficiency, and we've been seeing more of that in Costello syndrome. Tricuspid regurgitation, mitral regurgitation, less commonly aortic or pulmonary regurgitation. The second category of heart problem in Costello syndrome really has nothing to do with structure. I want you to almost kind of make a clean break. It has to do with this part of the heart, the muscle. And it's a fancy word called cardiomyopathy, heart muscle disease. Abnormal heart muscle. The house of the heart is assembled correctly, but not the walls. Now, I need to tell you that there's actually lots of different types of cardiomyopathy. The kind that we're talking about is this word hypertrophic, thickened. But just to let you know, there is a type of cardiomyopathy called dilated cardiomyopathy. You might hear of athletes getting a dilated cardiomyopathy or somebody dying of cardiomyopathy, please don't think it's necessarily the same thing. So hypertrophic cardiomyopathy means thickening of the lower part of the heart. It can be symmetric. Both sides are equally thickened. But what we see in Costello syndrome is the type called asymmetric cardiomyopathy. And this is the part that is mostly thickened, the septum, the middle part. Sometimes it's concentric, just like the word sounds, all around. Sometimes it's obstructive, meaning so thick, there's actually a gradient. There's more pressure down here than there is up here. Sometimes it's not obstructive. Now you must be saying, could you give me one term to remember? And you know what? There isn't one term. In fact, I often, when I'm being very pure about how I describe this problem in Costello syndrome, will not use the word hypertrophic cardiomyopathy. If I'm being very pure as a researcher, I will describe this problem as cardiac hypertrophy, heart thickening. Because hypertrophic cardiomyopathy to a cardiologist means really one thing. It means this thing, asymmetric cardiac hypertrophy. But to be kind of loose and to be kind of friendly, if I'm talking among friends, I might just use the expression hypertrophic cardiomyopathy. In the folder that Lisa wrote up, she used the expression hypertrophic cardiomyopathy. But among cardiologists, I try to be very precise, and I use the expression cardiac hypertrophy. They're about the same thing, and I think for the purposes of casual conversation, we use that expression. And as a show of hands, people here have children, I'm sure, who have cardiac hypertrophy? Of course. And we're going to come back to this a little bit more, okay, everybody? The third problem, okay, so we talked about structure. Heart muscle thickness has to do with rhythm abnormality. Remember I said the heart is like a house that has an electrical system. And the electrical system starts in the top chambers, goes down, just like a beautifully wired house. And there's a normal heart rhythm, a normal heart rate, and everything is beautifully wired. Well, if the rhythm is too fast, it's the word tachycardia. If the abnormality, the fast rhythm, originates in the top chamber called the atria, it's called an atrial tachycardia. If the origin of the pacing is in the same place, we call it a supraventricular tachycardia. And these words are going to have meaning later on. This is very common in Costello syndrome. But if the origin of this tachycardia is all over a crazy place, it's called chaotic atrial rhythm. That's self-explanatory, isn't it? It's a really great term. Some people call it multifocal atrial tachycardia, coming from many different places in the atria. Some people call it ectopic or junctional. And for each of these terms, if you talk to a cardiologist, there are slightly different distinctions. But what I'm finding is that some people use them kind of interchangeably. This is most precise. Okay? These are all seen. This is the most precise kind of signature for Costello syndrome. This is another type of fast rhythm in Costello syndrome, fibrillation. But if tachycardia is like this, fibrillation is like this. It's erratic, it's fast, it's kind of all over the place. It's a twitchiness. It's like a rhythm. And this is very uncommon, but it's something we've seen too. And premature beats just mean that the heart rhythm is going along pretty much on its own, but every once in a while there's an extra beat that gets in. But really what we think of as most common in Costello is the tachycardia, and most distinctively these kind of really erratic beats in ectopic places in the atria. Do we see ventricular abnormalities? Do we see rhythm abnormalities in the lower part of the heart? We do. Not too common, but it can happen. And do we see this other type of abnormality, which is called a heart block, in which you have the rhythm generated from the top to the bottom, but blocked in the middle? Very uncommon, and certainly not distinctive. Now, I've given you kind of this introduction, and now I'm going to take it, I'm going to present it to you in a different way. I'm going to give you a review, which includes material that I did in an article in 2002 and material that I'm presenting to a genetic meeting in 2005. More precisely, I've submitted it. The way we do things in medicine is if we want to present material, this is one way of doing it. We gather up our information, we show it to our colleagues, and we say, do we think we have something here that's worth presenting to more colleagues? We write it up in a short form, it's like a long paragraph called an abstract, and we submit it to a meeting, and then we wait a couple weeks, and we find out how the judges have judged our material. If they like it a little bit, we're allowed to present it as something called a poster, which is literally a great big piece of paper, like you do in grade school, called a poster. If they like it a little bit more, we're allowed to do it as something called a platform presentation, standing up at a meeting in front of a couple hundred people like that. So it'll take a couple weeks to find out whether this material will be presented as either a poster or a platform. And what this information, what this abstract includes, is an update of this plus this. So now we have at least the 94 patients from the original study, plus almost 60, and it's basically about 150. And something that Lisa and I and Karen do almost obsessively is we try to answer the question, how many patients are there with Costello Syndrome? We know that at least there are at least 150. We do a guesstimate. We think of, the patients in Japan we know about, the ones we've heard about in China, the ones we know of in South America. We know of patients all over the world. We know the patients who have not been in the literature. And we can say, surely there are at least another 50. So we come up with a round number of about 200. And there's a misprint in your abstract if you would correct. The frequency of having any heart abnormality has really been pretty consistent from then until now. It's over a half. I believe in round numbers. I have a very simple mind. I do not believe in giving you percentages of like 66.35%. I'm going to say to you, remember that any heart abnormality, any type, is about 2/3. Or you can even say to yourself, it's over a half. And then of these different types, having one of those congenital heart defects is about 1/3. But it looks like the cardiomyopathy and the rhythm abnormality might be a little bit more than before. I used to say 1/3, 1/3, 1/3, but it looks like these two might be maybe 1/2. But there's something that we call ascertainment bias. Wouldn't it make sense to you that the children who tend to have more problems might be the ones that their doctors would be more likely to report? And that the healthiest, happiest, happy-go-lucky children might not be the ones that would be reported in the literature. So it's hard to know exactly what this number is. Again, round numbers are fairly reliable. Let's say this. We would not say that these numbers are like 80% or 90%. Okay? Nor would we say that these numbers are like 10%. So I think we have a pretty good ballpark. I'm just going to pause for a second. Any questions?
Sorry, can you repeat that any heart abnormality number again?
2/3.
So that's a good
It's still about right. I made a mistake in my abstract. At least it says 1/3. But your folder's fine. And now, of the heart defect, again, having any type of a typical congenital heart defect, again, it's about 1/3. And this is what we've been saying all along. Still the most common one is pulmonic stenosis. The place where it is narrow is the valve itself. But just some information for those of you who might be interested. When the pulmonary artery can be narrowed, it can be narrowed at the valve, above the valve, something called supravalvular, and that's something new. And now we're starting to see something called coarctation, which we hadn't seen before, so this is new. And we're starting to see something called a bicuspid aortic valve. And I'm being like a Sherlock Holmes heart detective. We're just talking about 3 of these, 2 of these, and maybe 2 of these. But I'm filing this away. This is something we hadn't seen before, but in my mind this is starting to have a little bit of change. For me, what's interesting is what we don't see. We don't see a lot of really complex heart defects. Coronal truncal heart defects are the ones that we see in the syndrome that's called DiGeorge. You may have heard that mentioned somewhere else in the meeting. These are conditions that have the name truncus, tetralogy, transposition. Much more complex. Something called single ventricle, which is just like it sounds. It's a single ventricle heart. These are hearts where you can't list them by one word. You have to list them by like 6 different things. Heterotaxy is an abnormality in which the position of the organs are kind of all over the place. We just don't see that. And this, again, is a clue to me. Is the pattern of what we see in Costello, sorry about that. Is it unique? It's not. It's not. I can't say to you, what we have here is perfectly unique. It's like a fingerprint for a syndrome. It's not. Now, what else do we see in Costello? Do you remember we've talked about this before, folks? We see abnormal valves. We've seen mitral valve prolapse, and I know some of the children in this group have this. And we see some leakiness in the valve called regurgitation. The mitral valve and the aortic valve tips can be thick, and people use very colorful adjectives. Myxoid, valve dysplasia. I mentioned the bicuspid aortic valve. So I told you that this pattern is not a signature. It's not a fingerprint for Costello. So what else do we see it in? And I bet you've heard of some of these, of course. Noonan syndrome, where the children have an appearance like this. The eyes are widely spaced. They can have droopiness called ptosis. The ears have a tendency to have a lower position. They can have a little protrusion. They tend to have webbing of the neck. They can have pulmonic stenosis. They can also have cardiomyopathy. They have a gene. Most of the children have a gene. Those of you who heard Dr. Rowland's talk know that the gene is called PTN11. We call this our cousin in a way, CFCC syndrome, where the children often have a very similar facial appearance. They can have pulmonic stenosis. They can have cardiomyopathy. Pulmonic stenosis, about the same frequency. Cardiomyopathy, maybe a little bit less. A gene is not known. This is a syndrome that might be unfamiliar to you. It's called Alagille. It's the name of a French gastroenterologist. These children have something that's really quite different from Costello syndrome. They have a very severe liver disease. They require transplantation. They have cataracts. They have some other distinctive findings. They have widely spaced eyes. They have, some people don't even think they have a distinctive facial appearance. They absolutely do have pulmonic stenosis. They have some other defects, and there's a gene associated with them. And this is a condition called neurofibromatosis, in which there are many features. The cardinal feature is neurofibromas, skin tumors, predisposition to cancer, and many of the patients have wide-spaced eyes and a recognizable face. Pulmonic stenosis, it is the most common heart defect, but heart defects only occur in about 2%, so it's not really a really common one. Category number 2, the cardiomyopathy. How common? Remember I said a little bit more than a third, maybe about 40%. IHSS is just the abbreviation for idiopathic hypertrophic subaortic stenosis. You know, doctors love abbreviations, but it's such a long term. This is the common one, IHSS. And you can actually write it down, because this is a really common abbreviation. Or ASH, asymmetric septal hypertrophy. This is the most common type. But as I said to you, usually, most of the time it's left-sided. In a few of the patients, it's both-sided. And in some of the cases, it's unclear. I just don't know for the reports that I get. So, is this distinctive? No. Where else do you see cardiomyopathy? In Noonan syndrome, about 20% of the time. So a little bit less than in Costello syndrome. CFC, they don't see it as frequently. But you see it in these conditions that are called the storage diseases. How many of you have had children who have been thought to have mucopolysaccharidosis? So many hands are going up right now. And if you see this child, you might say, gee, this is a lot more severe looking than Costello syndrome. And yet, if you took this child's face and took it back to the age of, say, 2 months, 4 months, or 6 months, there is a striking, this is the best one that I could obtain from the web, there is a striking similarity. These hearts are massively severe, but they can be similar to what is seen in some children with Costello syndrome. However, these are stored, infiltrated with a highly distinctive product that can be instantly tested under the microscope. And for Costello syndrome, it's not a simple test. We don't have a test, in fact. There are other storage diseases, something called Pompe disease, something called glycogen storage disease. For cardiomyopathy in Costello syndrome, there is no consistent plan. But that doesn't mean, folks, there's not a plan. It's just that I'm going to give you a recipe. And I would say that Your heart doctor knows how to treat cardiomyopathy because they do. They may not have ever treated a child with Costello Syndrome, nor may they know exactly what to do at that moment. And they may need to do some networking and talk to some of the other doctors to find out what has worked best for them. For example, we know that in Toronto, they've had experience with taking care of more than one child with cardiomyopathy, and they may need to make a little effort to start calling around to find out from some of the other heart doctors who've taken care of more than one. Drugs can be, are used, can be used. I'm not saying they should be used. Customize the care for each child. Echo monitoring is definitely indicated. The question mark doesn't mean whether it should be used. It means what is the timing. I would never get up here and say it should need 1 month, 2 months, 3 months. It depends on the child. And for some of the children, it might need every 2 months, or for some of the other children, it might need every year. Surgery, this word myectomy means you do an operation to carve out what needs to be cut out. But that's not necessary for all of the children. It depends. It's required for some of the severe cases. I cannot stress enough that the care is customized for the child. Anecdotally, we have heard of children who have had very good responses to certain medications. And I have been asked at certain times if I would comment on that. And I said, that's not appropriate for me to do so. So what I've done is I've actually tried to contact the cardiologists who actually had some of the experience in caring for these children. But it's up to them to decide if that's appropriate for them to write it up as a single case report or a case series. Because really that is the way proper medical care works. You don't want one doctor who's had really good results with one patient to be out there saying it worked for me in case it doesn't really work for somebody else. I know this can be terribly frustrating. I've tried to respond to Lisa in many different ways. And I certainly want the very best for all the children. But single patient experience isn't necessarily always the best thing. More about cardiomyopathy, something that has come up, and I'm so pleased to have more data for everybody. Do you remember when we were talking about it before? Of course you do. In the article that I wrote in 2002, I addressed it. And I addressed it enough to say that it had been known. We had 2 measly little case reports. And the case report was from Canada, and it was just a simple mention that a patient had been treated with growth hormone. And in the original case report, there was not even a mention, though, about the heart. All we knew was that one patient had been treated with Costello Syndrome and with growth hormone. There was another case report from Oklahoma, and that was it. And theoretically, we talked about what might be the possible risk or benefits. In the 2003 meeting, I had said that I had anecdotally, between Lisa and I and the literature, started doing some counting. And we had seen some case reports. We knew there were some cases that had suggested we need to be a little cautious. Then we had heard of other cases that were saying, it can happen, it can be used, but it was very inconclusive. I knew that in Noonan syndrome, growth hormone had been used, and I thought, well, gee, if there's any similarity between the two, maybe we could use the two as possibly a model. So now, though, looking at some of the natural history data from Dr. Greer, I'm going to show you some more information. And things are improving without more data. Let me take you through this little table. What this shows is, first of all, some columns. This is data from Dr. Greer's natural history study, which includes so many of your children. This is information from literature. Literature means reports. And as I've joked, Karen and I and the other doctors, we call ourselves the Costello police. We get these articles, we look at them, and we become very judgmental because we feel that this is what is needed at this point. And that sometime there is a gene test where we can go out and allow children to be tested with a gene, then there's some patients that we might be more generous in including. But at the moment, for these kind of analyses, we only allow the very tightest cases to be counted. And we have a master list and a spreadsheet with all these little columns. And then this other column includes totals. Now I'm going to take you through the rows. This row says how many patients were on growth hormone and had cardiomyopathy. In a natural history study, we had 3. In the literature, 3 for a total of 6. And you might say, well, that's not exactly 600 or 60, but it's better than what we had before. And I'm going to try from memory to remember who these are, without naming names. One includes a young woman who was started on growth hormone, a teenager. It showed some development of cardiomyopathy, and it was thought to be true and related, and so that was stopped. Another one includes a young person who was known to be on growth hormone, but the development of the cardiomyopathy was so mild, that they weren't even sure if it was really related. The cardiologist following the person was such a good cardiologist, watching so closely, it was thought that it could be continued. So there were two different situations. And the third situation is also completely different. A child who had been on cardiomyopathy, on growth hormone for a while, had very severe cardiomyopathy, and was eventually taken off growth hormone. But there was a concern that there may have been a relationship, but still there is no proof. In the literature, the cases are less well described. But I can tell you that in at least two of them, there was a concern that they may have been true and related. But in one, there's a concern there may have been true and related. In two, you simply know that they were on it and got cardiomyopathy. So we have some suggestion that possibly there might be some relationship, but in others there might be an association. You understand the difference, folks? Cause is, yes, yes, cause. Association means yes, yes, but who can tell? And a lot of it has to do with whether it's somebody under one's observation, being carefully monitored like every couple of months, or whether it's something that you just happen to notice. It's very hard. Also has to do with severity and age of the child. The second row is somebody who did not get growth hormone but got cardiomyopathy. 8 in the study, 11 in the literature, 19. Now here's a group. Growth hormone, yes. Cardiomyopathy, no. 4 here, 8. So even though the top row is the one we're kind of watching, this group is really interesting because they certainly had no growth hormone, but they got cardiomyopathy. And this group is awfully interesting because they were on growth hormone but didn't get cardiomyopathy. This group down here, folks, are the ones where neither growth hormone, no cardiomyopathy. In the natural history study, that's 15, and then there are a whole bunch of literature, probably like 90 or so. There's a minimum of at least 7 plus 7 plus 14 who've been on growth hormone. Now, what doctors like to do when you create a table like that, we like to do a calculation called an odds ratio. We like to come up with a percent, and these numbers are too small to do it. But I'm very pleased that we have something to be looking at, and we have some patients who are literally under a microscope being watched, whereas others we still cannot draw conclusions. But I still think that there's something there that is, progress. This type of data would probably not be pulled together and written up as any special paper or anything like that. I have no plans for it immediately, but it will be contributed to Dr. Doyle's study eventually. I'm going to complete the talk, and then we'll come back and try to talk about that some more. But back to rhythm abnormality. How common? Remember I said about a third? A lot of times these rhythm abnormalities, in fact, most of the time, folks, these aren't things that plague people for their whole life. It might be a tachycardia in the womb. In fact, it's a really distinctive sign for Costello Syndrome or infancy, and then it usually seems to go away. Again, it's usually an atrial tachycardia or one of those unusual types, chaotic, SVT, multifocal ectopic. And we know one patient who has something called a prolonged QT interval. If you ever looked at the EKG, it's like a series of mountains and valleys. And each of those intervals has an initial for it, P, Q, R, S, T, and we measure intervals, and they have a different length that they're supposed to be. One of those intervals is called QT, and we monitor that. And it has a certain significance. I'm not going to really talk too much about it. We're aware of it, and it needs to be studied, and probably we'll have a little more follow-up later on. These things can be combined. This and this, all three together. We've been looking for associations to see if one causes the other causes the other, one comes first, and they're not consistently associated. So this is some of the new information, and I have to thank the parents who literally come up to me at meetings to say, Dr. Lynn, are you aware of such and such? And most of the time I would say, you know, I have no idea. It took me several years. It took me at least 3 years to accumulate. Because what doctors generally do is, we take what you say. I literally take information, I make notes myself, I put it in a file, and I wait until I know a little bit more. I start to digest it. And then you reach a critical mass and you say, okay, this is something that is worthy. Talk to other people, and now the time has come. And so what we're talking about is we now know that there are 4 patients with aortic dilation. The aorta, the arch, at the very takeoff point is a little bit stretched. This could mean this is just a characteristic feature, because in Costello syndrome we know that connective tissue is involved. We know the children have all the loose joints, the skin is stretchy, and we might find that the aorta is more often stretched, so it's dilated a little bit bigger. A dilated aorta is seen in other disorders of connective tissue. There's something called Myectomy Syndrome. At the moment, all I'm doing is noting it, trying to get some measurements, and we're going to tag it. Of all the things to tell you about, it's actually difficult to tell you about this, because this is a child. This was a child that was known to us 2 years ago. This was a darling little boy that all of us knew, who then developed a stroke and passed away. And this was a little boy that we all knew. And he was found to have, in his brain, the arteries that perfused his brain were found to be abnormal. Some were narrow, some were dilated. And the medical word for this is called cerebrovasculopathy. This is not the kind of stroke that an older person might get when you have a blood clot and then you have a bleed. This is the type of blood vessel problem where they seem to look abnormal from a congenital way. This is how his blood vessels were formed. He is the only one with this, and we do not know exactly what it means. But we know of a child in the United Kingdom in which she had cardiomyopathy and she passed away, and it was the coronary arteries on her heart. They were not the same, but there was something about them that was different. We noted them, and now we have to make others aware about this, including ourselves. We know of 2 small children, to me small meaning toddlers, beginning with less than the age of 5, with high blood pressure, one of whom had blood pressure that was high in the lung field, called pulmonary hypertension. See, when we say blood pressure, what we're talking about is blood pressure in the arms and the legs and the body. But the pulmonary arteries have their own pressure. It's independent from the rest of the body, and we call it pulmonary hypertension, and this has been observed too. We know of one teenager who has mild hypertension, and then in Sue White's study, we now know of an Australian adult, Dr. Costello's individual, who also has hypertension. I also mentioned somebody who has the coarctation, which is called a supravalvular pulmonary stenosis. If you take it all together, what these reflect are arteries. This is called, the fancy word is arteriopathy, and this would be consistent with what we think is going on in Costello syndrome, that in terms of the cardiovascular system, we're talking about arteries. Again, is this unique? This is very similar. To a cardiologist, the first thing I thought of is something called Williams syndrome. Williams syndrome is known to be due, you know about its gene. We know about its biochemical abnormality called elastin. The facial appearance is this. This is an older child and a younger child. Very endearing appearance, fullness of the lips, a wide mouth, a fleshy nose, fullness around the eyes, prominent ears. People use the expression elfin, I'm not sure if it's applicable, but a very distinctive facial appearance. I think what it brings us to is where we've been before, which is how should we care for our children and older children with Costello syndrome? Part 1 is really easy. Every child, every individual with Costello syndrome at every age, absolutely positively, definitely gets a cardiology consult to diagnosis. So it's not enough to say, my pediatrician had a good listen. And this is where I can certainly help you when I say I'm an advocate for you. This is when I will take an active role to ensure that it's a cardiology consult that should include an echocardiogram and an EKG. If you said to me, my heart doctor, my pediatrician had a really good listen and got a chest x-ray, I would say that is not enough. You shouldn't get an echocardiogram. In italics, I put, ever so tactfully and practically, consider or discuss a Holter or 24-hour monitor. Because I would never tell the cardiologist what needs to be done. If the cardiologist is seeing, for example, a 12-year-old who has absolutely no heart problem and has followed this child and says, this child is otherwise fine, I could certainly agree why a cardiologist would say it's not appropriate to get a Holter at that time. But pretend the individual being evaluated is a 1-day-old who has already is having some issues in the nursery, is unstable. That might be the very child who is going to need the Holter to find out what else is going on. So that is the kind of setting where this might need to be done. Do you see what I'm trying to say? You must customize the care. The natural history for Costello syndrome, including the heart, is incomplete. My feeling is that cardiac studies need to be repeated at some point. If it's an infant, it needs to be done again at some point. But when is the other point? Well, if the heart is absolutely perfect, it may not need to be done again for a year. If the heart starts out as abnormal, well, the cardiologist will take it away. They know when to do it. I don't need to tell them to do it. I don't really need to put a recommendation in. If the heart is already normal, should it be done again? I would probably say yes, because you need to be thinking about the cardiomyopathy. And I feel that a good cardiologist who knows about Costello syndrome will figure that out on their own. If they've never seen Costello syndrome, it would be probably worthwhile that they would say, could you fill me in on the literature, make them aware of my article, or they'll go and do their own web search and get the article themselves. In children who've been seen, I think it probably needs to be done again until we have the natural history. If there's some time when I can come back to you and I can present you a timeline from the fetus, infancy, toddler to adulthood, have it all marked out, then we'll have this perfect timeline and we won't have to have any guessing. Each time that I've come to you, we're getting a little bit better, but we're not there yet. But I've been really reassured after reading Sue White's paper, which is only online. When it becomes available as a PDF, it will go from me to Lisa and then to you. She has not written about any adults who have suddenly gotten bad cardiomyopathy, sudden arrhythmias. She has talked about hypertension. There is the Costello patient, so that might be the one thing we're going to have to watch out for. Okay. And if an abnormality is present following the cardiologist, special problems deserve special evaluations. So which heart problem, future directions, questions, and insight, which heart problem comes first? Does the tachycardia result in deterioration of the conduction system? We don't have any evidence that the conduction system is suddenly falling apart. We have some concern that maybe cardiomyopathy might be related to it, but no proof yet. Does the cardiomyopathy reflect a biochemical problem throughout the body? You see, there's always been this concern that Costello might be a storage problem, but we don't see any storage product in the liver. We don't see it in the skin, but we know that the heart gets very thick. But we do have a partial answer. I'm trying to show you how there's been some progress. There was a paper that was published this year, and it was a great collaboration of so many of us. Dr. Hynek, who is a cardiovascular researcher. He's a PhD, not an MD, at the Hospital for Sick Children in Toronto. And Karen and I participated, and Lisa, and several other individuals. And what he showed was in the American Journal of Medical Genetics. In the heart, myocardium, there was storage, but not storage in the sense of big chunks of material. I don't want you to be misled. It wasn't something that somebody could just see. This required special staining. There was a material called chondroitin sulfate. Moieties is a fancy word for things, of a special type that could be seen. It was massive. He could stain for it. It was something called a proteoglycan. And there was a reduction in what are called the elastic fibers. And right away that should ring a bell or light up a light and think elastic fibers. Isn't there something about elasticity in Costello syndrome? It's kind of all fitting together. And didn't Dr. Lynn say there were some similarities or overlap with Williams syndrome, even though this isn't Williams syndrome? The particular type of chondroitin that Dr. Hynek saw was a type called 6 that was increased, and there was a type that was decreased called number 4. Now, in his mind, it might have been a clue to an imbalance, possibly enzyme deficiency.
But this, folks, is just one theory. I would never want you to walk home from here, fly home from here and say, oh, they think it's an enzyme deficiency, because that's not it at all. What this is showing you is one step, one piece of research. I'm a very upbeat person. I like to show progress, and I felt that this was a very worthwhile paper. That's why we published it. Dr. Rauer is working on her end of it from a gene point of view, and I just want to show you that all your contributions allowing us to meet your children, to work with them, is starting to pay off. And I think that's my last slide. Just a little bit more. I'm very interested in delineating the natural history of the hypertrophy, the tachycardia, what happens to the heart in adults. So far, no signs of sudden, dramatic progression. If I was a parent, that would be a terrible concern. I'd be constantly watching my child, and I'm sure you do too. What are the greatest risk factors for death? What can parents do to prevent worrisome rhythm problems, if anything? Of the rhythm abnormalities, we want to confirm this predominance of atrial tachycardia. So I think we have. Look for the subtle rhythm problems or conduction problems. Think about sudden death, what are the correlations? Determine best treatment. If there really is a best drug out there, Lisa, I'd want to know about it and shout it out and try to find it, but we need the help of the cardiologist and perform, this is something for other people. Study cardiac hypertrophy, what part of the heart is affected, age of onset, progression, correlate to sudden death, younger children, sudden treatment. And I want to thank you for your attention. I know it's hard, and I'd like to handle any questions. Thank you.